सर सर को डिस्क्रिप्शन बता दिया।
Hi everyone. Srikanth has unnecessarily created a problem. He unnecessarily said a surprise speaker or anything. Nothing like that. It's my talk only. I'm presenting before my teachers. That is the highest irony. Okay.
Hello.
Hi.
Screen ఒక్క నిమిషం. అది ఫుల్ స్క్రీన్ రావట్లేదు, అది ప్రాబ్లం. అది ఆలోచిస్తాను.
ఓకే.
Are you able to see? పెద్దది వచ్చేస్తుందేమో కదా. హలో
హలో.
స్క్రీన్ పెద్దది వస్తుంది కదా, ఫుల్ స్క్రీన్ రావట్లేదు.
కొంచెం హాఫ్ కింద వస్తుంది.
అలా వచ్చేస్తుంది.
నాకు అస్సలు టెక్నికాలిటీస్ ఏమీ తెలీదు.
Bashir, can you share the screen? Laptop లో లాగిన్ అయ్యారా? హలో బషీర్ పడుకుని పోయాడంట.
లేకపోతే ఎంత కనబడితే అంత చూపిస్తావా? నేను తర్వాత పీపీటీ పెట్టేస్తాను గ్రూప్ లో.
చందన అది పీపీటీలో ఉందా, పీడిఎఫ్ చేస్తారా?
పీపీటీలోనే ఉంది.
నీ దగ్గర పీపీటీ యాప్ ఉందా? ఇది వర్డ్ ఉందా? వర్డ్ యాప్ ఉందా?
లేదు 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 లేదు.
నేను షేర్ చేసేస్తాను. మీరు చేస్తారా?
నేను చేస్తాను, కానీ అదేదో పెద్దగా వస్తుంది అంటున్నాడు శ్రీకాంత్.
ఒకసారి
నేను షేర్ చేసేయచ్చు. యూ టర్న్ యువర్ ఫోన్ హారిజాంటల్లీ అండ్ షేర్ కంటెంట్ అని ఉంది కదా,
అది ఓకే. ఐ విల్ సీ.
ఆ షేర్ కంటెంట్ మీద క్లిక్ చేయండి.
ఓకే,
చేశారా?
అంత స్పీడ్ ఉంటే నేను ఎప్పుడో బాగుపడను. ఓకే, ఇప్పుడు ఎక్కడ ప్రొజెక్షన్ లో పెట్టాలా?
షేర్ కంటెంట్ కి వచ్చిన తర్వాత స్క్రీన్ అని ఉంది చూడండి.
షేర్ కంటెంట్ అనేం లేదే
మధ్యలో. ఇక్కడ జూమ్ లో అడుగుతున్నాను నేను. జూమ్ లో.
ఓకే 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 ఓకే.
గుడ్ మార్నింగ్ శేఖర్.
గుడ్ మార్నింగ్ సార్.
లేట్ అయిపోయింది, చాలా ఫీల్ అయిపోయాను.
లేదు సార్,
ఏం
స్టార్ట్ అవ్వలేదు సార్. నాకు అస్సలు తెలియట్లేదు శేఖర్.
యు క్లిక్ ఆన్ యువర్ స్క్రీన్.
షేర్, ఐ గాట్ ఇట్.
షేర్ స్క్రీన్ అని చూడండి.
ఓకే,
వచ్చిందా?
ఏమో చైతన్య ఏదో షేర్ చేస్తుంది. అందరూ షేర్ చేస్తున్నాం.
మీ ఫోన్ హారిజాంటల్ గా పెట్టండి ఫస్ట్.
ఓకే, మీకు ఏమన్నా కనబడుతుందా?
You are sharing your screen, like I can see.
Oh, where can I see my screen?
మీరు మళ్ళీ క్లోజ్ చేస్తారు.
Okay. This is nuts. Yeah, I don't know. Shit.
లేకపోతే పీపీటీ నాకు పంపించండి, నేను షేర్ చేస్తాను.
Okay. వచ్చిందా మీకు?
లేదు యా రాలేదు. సార్ ఇది మెసేజ్ పెట్టారు, అది వచ్చింది.
మ్యామ్ మీరు ఇంట్రొడక్షన్ స్టార్ట్ చేయండి, నేను పంపిస్తాను సార్కి.
సరే సరే, ఓకే. సారీ ఫర్ ది డిలే. సో టుడే ఐఎమ్ జస్ట్ sorry to disappoint you, Mohan sir. Not from Mumbai. So the topic which I'm talking today is about methemoglobinemia and anesthetic considerations. So before we go on to
full petra
answer
screen full petama chaitanya
సార్ అవి వెర్టికల్ స్లైడ్స్ ఉన్నాయి సార్, అందుకనే ఫుల్ స్క్రీన్ అవ్వటం లేదు.
సైజ్ పెంచు చాలు పెట్టేసి. చేయండి అమ్మా, చందన స్టార్ట్ చేయండి.
Yeah. So before we go into methemoglobinemia, I just want to tell a few words about hemoglobin. This is just a representation. I was just thinking like hemoglobin is like a car and the 4 seats are like 4 subunits of hemoglobin, each with one globin part and one non-protein, that is the heme part, and the heme part containing the iron molecule and protoporphyrin. The next slide please. So this is the hemoglobin structure. Next slide. Okay. So shall I continue?
Please.
Yeah. The hemoglobin structure, as we all know, it has 2 alpha in adult hemoglobin, that is HbA, which is comprising about 95% of the total hemoglobin. It consists of 2 alpha globin and 2 beta globin chains, which are attached to the protoporphyrin along with the iron molecule in the ferrous state. So why I'm insisting upon this iron molecule in the center of hemoglobin is the iron has 6 valencies, as we all know. Among the 6 valencies, the iron binds with 5 nitrogen molecules present in the hemoglobin. The nitrogen is supported by the 4 pyrrole rings and 1 from the histidine. The histidine, proximal histidine of the globin chain. The distal histidine of globin chain is binding loosely with the iron along with the oxygen by van der Waals forces, and in deoxygenated hemoglobin state we find that it is binding with the water molecule. Then come the T forms and the R forms of hemoglobin, that is the tight and relaxed forms. Sir, I'll share the PPT again in the group. I'm just continuing. We have the T and the R forms. The tight and the relaxed forms of hemoglobin are the tight form is nothing but the deoxygenated form of hemoglobin. It consists of the salt bridges. Excuse me, just a second. Sorry. So the tight forms, as we all know, the tight forms have salt bridges which are attached to the hemoglobin molecule with the 2,3-DPG in the center of the hemoglobin molecule. As the oxygen starts binding with the tight forms, the affinity of the hemoglobin towards the oxygen increases and the salt bridges break, and slowly the 2,3-DPG molecule comes out and the hemoglobin is loaded with the oxygen molecules. So that is the relaxed form. So this we see in the normal physiology, where in lungs we have higher concentration of oxygen, PO2 levels are raised, and the oxygen competes with the hemoglobin and it binds with the hemoglobin iron in ferrous form, and we get oxygenated hemoglobin. The reverse happens in the tissue level. So what's the deal with methemoglobin? So methemoglobin is nothing but metamorphosis of the hemoglobin. We can say it in that way. So in chemistry, we know that the oxidation can result from either gain of oxygen, a loss of hydrogen ion, or a loss of electron. So in methemoglobin, the ferrous form, it will lose the electron and get oxidized and forms ferric form. So there is a difference between the oxygenated hemoglobin and oxidized hemoglobin. The oxygenated hemoglobin is the normal hemoglobin in which the iron is in the ferrous form and it transfers the oxygen. Whereas in ferric form, the iron loses its capacity to carry the oxygen. And hence we get a functional anemia. So how does body deal with methemoglobinemia? Normally, in normal physiological conditions, the blood cells tend to produce methemoglobin to certain extent, but luckily RBC have methemoglobin reductase pathway, so which curtail the amount of methemoglobin which is produced in the RBC. So this happens with the cytochrome B5 reductase enzyme and cytochrome B5 NADH pathway. This is the most at 7th slide. Yeah.
This one?
Yeah.
Okay.
Thank you. So the NADH, which is normally produced in the glycolysis pathway, it gives the electron to the cytochrome B5 enzyme in the presence cytochrome B5 in the presence of cytochrome B5 reductase enzyme. This enzyme is either this enzyme deficiency or cytochrome B5 deficiency can lead to inherited methemoglobinemia. So what happens is this cytochrome B5, which is in reduced form, it gives the electron to methemoglobin and thereby converting the methemoglobin to our hemoglobin. So what are the other ways in which methemoglobin occurs is during oxidative stress, the methemoglobin and Heinz body hemolysis occurs, which is because of clumping of the globin chains in the RBC. The next slide, please. Yeah, thank you. So the methemoglobin, as I have said, most of the methemoglobin is converted back to deoxygenated hemoglobin, which is in the ferrous form with the help of NADH cytochrome B5 reductase, and this NADH is coming from the glycolysis pathway. So the other methods in which the methemoglobin is converted back to hemoglobin and the essential pathways are the glutathione reductase pathway, ascorbic acid pathway, and NADPH methemoglobin reductase. These account for a very less percentage of conversion of methemoglobin back to hemoglobin in normal conditions. When does it have importance is when the concentration of methemoglobin in the body rises to a very great extent and our body is overwhelmed with the amount of methemoglobin and it cannot be converted by the routine NADH cytochrome B5 reductase, which is normally present, back to hemoglobin, and then we have the presentation of methemoglobin. So this NADPH pathway, NADPH is contributed by the HMP pathway. So this NADPH methemoglobin reductase enzyme is potentiated with the help of methylene blue, which we use during the treatment of methemoglobin. So next slide, please. So what happens in next slide, please. So what happens in methemoglobinemia is it cannot carry oxygen and it causes hypoxia and functional anemia. The cyanosis is a central cyanosis because of increased concentration of methemoglobin concentration. there occurs secondary erythrocytosis and reticulocyte counts are increased to certain extent. Then why does there is as we all know, in ODC curve there is a shift of ODC curve to the left in methemoglobinemia. What happens is the methemoglobin, it is not necessary that all the 4 iron molecules in the hemoglobin convert into ferric state, but at least 1 or 2, even if they are converted into the ferric state, the rest of the iron molecules tend to have a strong affinity to the oxygen and they don't deliver the oxygen. That is one thing. And the other thing is the total concentration of the hemoglobin which is present in the blood decreases. The oxygenated hemoglobin as such decreases in the blood, thereby the oxygen carrying capacity is very much reduced in methemoglobinemia, which contribute to the disease process. So normally our hemoglobin levels are about less than 1%, and this less than 1% is maintained because of the reductase pathways which we have discussed about. Next slide, please. Next slide, please. So in according to oxygen cascade, we know that there is high PO2s at the lungs, which compete with hemoglobin, and thereby there is increased oxygenated hemoglobin. When we go to the tissues, what happens is there is increased level of 2,3-DPG, less pH, and increased amount of carbon dioxide, and Haldane effect comes into play, and there is release of oxygen into the tissues. This is what normally happens. If we can see the oxygen saturation, SaO2, normally in pulse oximeter, this is what happens. It only calculates the deoxygenated and oxygenated hemoglobin, and the oxygen saturation is represented as oxyhemoglobin by oxyhemoglobin plus deoxyhemoglobin. This holds good when normally. But what happens in dyshemoglobinemia? The amount of hemoglobin which is not functional increases. It could be either methemoglobin or sulfahemoglobin or carboxyhemoglobin, whichever is not functional. So the oxygen saturation as such is oxyhemoglobin by oxyhemoglobin plus. So how do we diagnose? When we come to diagnosis, either by clinical presentation, ABG. In ABG, we come across saturation gap, co-oximetry, bedside filter paper for blood color evaluation, and we have to rule out other causes of hypoxia from cardiac, CNS, pulmonary regions, and we go for the routine tests of CBC, reticulocyte counts, LDH. It increases. Indirect bilirubin, sometimes it increases. Haptoglobin concentrations increase. Peripheral smear, especially in G6PD deficiencies, we find bite cells and hinge bodies, and serum levels of nitrates if possible, and enzyme assays if it's in a congenital or inherited methemoglobinemia with G6PD levels and cytochrome B5 levels, and electrolyte concentrations, and any other toxic drug evaluation if possible. So clinically, when we see the patient, initially we find central cyanosis. Central cyanosis is presented when the amount of deoxygenated hemoglobin is in a higher percentage in the body. So in methemoglobinemia, we find central cyanosis because the amount of hemoglobin which is not oxygenated is pretty low. Not oxygenated is pretty high and oxygenated is pretty low. And as we can see here, after treatment, the patient's coloration has changed. Now coming to another issue of pulse oximeter. So what's the deal with the pulse oximeter? The pulse oximeter is designed for normal calculation of the oxygenated and deoxygenated hemoglobin. So we have calculates in the wavelength with greatest absorbance at 2 wavelengths, that is 660 and 940. The 940, it calculates the oxyhemoglobin, and the 668 deoxygenated hemoglobin, and the difference is shown here in pulse oximeter. But with dishemoglobinemia, what happens is there are two other hemoglobins which compete with these wavelengths. So methhemoglobin, it has a similar absorbance at both the 940 as well as the 660 nanometers, as well as the carboxyhemoglobin. It's almost similar to that of the reduced or deoxygenated hemoglobin. So what is the problem here is, in methemoglobinemia, the severity of the disease cannot be assessed because of this false readings which we see in the pulse oximeter. But is pulse oximetry not useful? No, we can't say so, because pulse oximeter is an indirect way. It gives a hint that something is going wrong, because in spite of supplemental oxygen, the cyanosis does not resolve, or there is no improvement in the saturation. This should prompt us to see where the issue is, and then comes the co-oximeter and co-oximetry. Yes, then as we can see, oxyhemoglobin and deoxyhemoglobin, the absorption is at 660 and 940, but methhemoglobin, there is an equal absorption at 660 and 940. So if the concentration of methhemoglobin is like 20 to 30%, then still the saturation SpO2 in the pulse oximeter is shown as 85%, and it gives a false assumption that the methhemoglobin concentration is increasing. So once we get a doubt, we have to check with the co-oximeters and ABG with co-oximetry in ICU. So next slide. Next slide. Yeah, these are the co-oximeters, and next slide. Yeah. Now, if say we have encountered a patient in the ER, and the patient has a abnormal saturation in the pulse oximeter with 80 to 86%. Now you have sent the ABG, but your ABG machine has no analysis of methemoglobin. So there you see a PO2 levels of very high value, and also SO2 levels of high values. SO2 levels are very high in the given reading, because SO2s are calibrated in the routine ABG machines according to the normal ODC curve, and also it disregards the presence of dishemoglobins. So the SO2 levels are pretty high in the ABG values. So now the saturation gap is coming into play. So we calculate it as SO2 minus SpO2, and if it is like more than 5%, then you have to seriously think about dishemoglobinemia and send the blood sample to a co-oximeter ABG machine, where the methemoglobin percentage can be evaluated and estimated. Next slide, please. So here we can see, initially the oxyhemoglobins in this arterial co-oximetry is around 60 to 90%. But on the top panel, we can see that the SaO2 levels are 94 to 100%. And at the time of diagnosis, the oxygenated hemoglobin, that is the actual oxygenated hemoglobin present in the co-oximeter, is only around 59 to 60%. But the SaO2 levels are pretty high, 96.3%. So once the treatment has started, the SaO2 levels not much change is seen, but the oxygenated hemoglobin in the panel is gradually increased up to 94.3%, and the methemoglobin level has decreased from around 38% to 2.2%. So this is the cliche where importance of co-oximetry comes into play. Next slide, please. So this ABG analyzer is present in Care 2, which we have used for our case, that I'll tell you later on. So next slide, please. So here in the co-oximeter machine, we can see in the top panel, the percentage of the different types of hemoglobins, the oxyhemoglobin, the methemoglobin, the carboxyhemoglobin. So individual percentage of each and every hemoglobin can be seen. Next slide, please. Coming to bedside, when we are drawing the sample, we can see that the blood of a normal person, if it's oxygenated, it is almost like cherry red. If it's deoxygenated, it is red, but dark red in color. But when it comes to methemoglobin patient, the blood is chocolate brown. A simple test is once we can put the blood sample on a filter paper and we can leave it to the oxygen room air with increased percentage of oxygen. If the color change is present from brown to reddish color, it indicates that the enzyme levels of that methemoglobin blood is okay. So there is no G6PD deficiency. If there is a G6PD deficiency, the color tends to be brown throughout. Or if it's a dyshemoglobin other than methemoglobin, like sulfahemoglobin, then also it tends to be in the same color. The color doesn't change. Coming to G6PD deficiency, if we see the smear shows, as we have said, bite cells and hinge bodies. Hinge bodies are clumping of the globin molecules, and these cause premature lysis of the RBC in the blood, and it may increase the haptoglobin levels and also hemosiderin molecules and presence of hemoglobinuria in certain conditions. Next slide, please. So when I was reading about this topic, I came across this inherited hemoglobin Fugate family. This is a pretty famous family which is present in almost whenever we click in Google Methemoglobinemia, you find this blue family. Here in this family, there was a lot of inbreeding, and it was cytochrome B5 reductase enzyme deficiency, which is inherited as autosomal recessive. Because the initially the parents were not showing the gene, and once they have conceived, 4 out of 7 children turned up blue. So it happened that there was a lot of inbreeding because nobody was willing to marry or whatever. So because of lot of inbreeding, lot of children were born blue. And one of the last generation happened to see the doctor, and he was treated with Methylene Blue, and they started using Methylene Blue orally ever since, and the disease got controlled. Just a fun fact or interesting fact. Now, when we come across the type of enzymatic deficiencies, the NADH cytochrome B5 reductase enzyme deficiencies can be of type 1 to type 4. Type 1 is the most common, which is affecting the red blood cells. Type 2 is it's a more generalized disorder which affects the all other tissues, including the central nervous system. And type 3, it includes the hemopoietic cell lines. And type 4, it is the deficiency of cofactor cytochrome B5 and not the enzyme deficiency. And a note on hemoglobin M disease, that is autosomal dominant disease. In this disease, there is a mutation in the globin chain. If we can review, in the globin chain has a histidine molecule which presents the nitrogen to the valency of the iron molecule. So this histidine molecule is replaced by tyrosine or any other amino acid. So because of this mutation, the globin chain tends to change its change its shape. Because of the conformational changes, the iron molecule is exposed to the oxidation stress, and the iron is oxidized to ferric state, and this is almost like a permanent methemoglobinemia. The hemoglobin will not, the oxidized iron will not go back, and it will not be affected by the reductases enzymes. Then coming to medications, acquired form of methemoglobin, which is more common when compared to inherited variety. There are multiple drugs which are indicated in presentation of methemoglobinemia, like I just put A, B, C, D for my recollection, or we can have a form in patients whom we are suspecting with methemoglobinemia and can just take whatever antibiotics or whatever drugs they are taking so that it becomes easier. So these are like the aniline dye, anti-malaria, chloroquine, primaquine. In history, people, you are using dapsone, chlorids, exposure to lot of amount of nitrates, and I have read few articles where anesthetics, benzocaine, prilocaine, they have been used, and benzocaine, which is used during the bronchoscopies. The patient was previously normal, but if they have the tendency to produce to develop methemoglobinemia, they tend to produce methemoglobinemia because of benzocaine spray 20%. So these are the drugs which are potentially implicated. When coming to severity, up to about 3% of concentration of methemoglobinemia, generally no symptoms are seen. Up from 10 to 20% mild symptoms like cyanosis, chocolate colored brown blood is seen. And from 20 to 50% dyspnea, decreased exercise tolerance, a lot of dizziness, tachycardia is seen. More than 50% CNS hypoxia, seizures, tachycardia, metabolic acidosis, and more than 70% is fatal. Treatment with severe methemoglobinemia, once the percentage is low, we have to immediately start, because it's life-threatening, we have to immediately start treatment with methylene blue, ascorbic acid, if needed, hemoglobin transfusion. So in acquired methemoglobinemia, the other most important thing, if in drug history, if we know there is a potential drug which can cause methemoglobinemia, it immediately to withdraw the drug and withhold and not allow any other drugs which can cause methemoglobinemia. And in chronic mild methemoglobinemia, like in inherited forms, the patients are more blue, but they are less sick. So next slide, please. So when we come across cyanosis evaluation, we have to keep into consideration not just methemoglobinemia, but other dyshemoglobinemia, most commonly sulfhemoglobinemia, and then whether it is hereditary or whether it is acquired. And then again, whether methylene blue, which we are giving, will be effective or not effective. So for that, if there is any G6PD deficiency presence or not. If there is G6PD deficiency, then our methylene blue might not be effective and we have to go for other lines of treatment. And if it is any other dyshemoglobinemia, then also our treatment might not work out. So coming to methylene blue, next slide, please. Next slide. So methylene blue, it is available both orally as well as in IV forms. So IV 1% is the solution in which it is present in vials or ampules. And the dosage is 1 to 2 mg per kg body weight, and repeat dose can be administered after 30 to 60 minutes. Avoiding doses more than 4 to 8 ml is recommended because methylene blue itself can cause oxidation and itself can cause methemoglobinemia, and it itself can have a false report in the pulse oximetry. Even with methylene blue, the absorption range in the pulse oximetry is around 660 nanometers. So what is the mechanism of action of methylene blue? As we have seen, from the HMP shunt, the NADPH is released. From the NADPH donates the electron to NADPH methemoglobin reductase enzyme. which gives the electron to methylene blue, which is in the oxidized form, and it forms leucomethylene blue. This leucomethylene blue donates the electron, and the methemoglobin ferrous form, it releases the electron and it forms the ferrous form of hemoglobin. Or if it is present in the tissues levels and deoxygenated hemoglobin, if more amount is present, it might be in the oxygenated hemoglobin. So what are the other treatment modalities? They are the ascorbic acid, N-acetylcysteine, cimetidine, exchange transfusions, hemodialysis in severe cases and acute cases. Coming to perioperative management, the most important is arriving at the diagnosis, suspecting if SpO2 is low without any clinical reasons, and confirming it with co-oximetry. Coming to determination of underlying disease, any congenital enzyme deficiency, hemoglobin M, or drug-induced. Drug-induced being most important because it is easily treatable. Then considering any comorbid condition, and treatment by removal of the offending agent, giving methylene blue, ensuring adequate oxygen delivery throughout the process, and ensuring there is adequate cardiac output and there is an effective oxygen transporting hemoglobin present. So if there is a anemia or any other problem underlying, it is better to give some amount of blood transfusion. Not that immediately there will be increased oxygen transport because of very low levels of 2-3 dpg in stored blood, but at least after 24 hours we can expect a rise in 2-3 dpg even from the stored blood, and there is increased oxygen delivery at the tissue level. Now coming to intraoperative care, avoid all the medications which can exacerbate condition, especially if the patient is having a known underlying methemoglobin. Then it is better to avoid all the drugs and also consider additional monitoring with ABG, co-oximetry, oxygenation, hydration, homologous blood transfusion, keeping it ready, hyperbaric oxygen therapy. And at a diagnosis of low SpO2, always confirming it with co-oximeter and repeated sampling during the operative procedure. Now coming to approach to the patient with cyanosis, it's in a nutshell. When a patient comes with cyanosis, look for other clues of methemoglobinemia, like with saturation gap, no change in pulse oximetry even with supplemental oxygen, presence of a chocolate color red, and testing for presence of methemoglobin percentage. Look for the potential culprit medications and remove those medications, and with an ongoing supportive care, and then considering supplemental oxygen along with treatment of any comorbid issues, as well as ruling out any severe comorbid issues. And if the symptoms are very high and the methemoglobin levels are very high, then treatment with methylene blue if there is no J6PD deficiency, and also addition of other agents like ascorbic acid. It proves to be helpful to certain extent, because how does the ascorbic acid act is it directly removes the oxidation radicals, thereby decreasing the oxidation potential of the hemoglobin to convert into ferric oxide. So we came across one patient in care 6 months back or so. She's a female patient. She's in her 40s with history of methemoglobinemia. She had underwent a toenail surgery in her childhood when she was diagnosed with methemoglobinemia. Her enzymatic workup was done and ruled out for G6PD deficiency and cytochrome B5 reductase deficiencies. She has a history of central cyanosis in between with few exacerbations on and off with the oral methylene blue treatment and ascorbic acid treatment. She has saturations between 88 and 93 pulse oximeter at the time of presentation during the PAC workup. And she has no other history of SOB, dizziness, weakness, and she was able to do her routine daily work. And there was still cyanosis present at the fingertip. Tongue was a bit pale, and her ABGs at that time, we asked them to send, but in care 1 they were not there, but then they have agreed to take the sample at care 2. where her methemoglobin levels were around 11%. Then other workup was done with CBC, platelet, electrolyte, serum creatinine, ABG sample has she was informed regarding the surgery risk. Both laparotomy and laparoscopic was explained to her, and hematologist consultation was taken, and labs were intimated that repeatedly we will be sending ABGs for evaluation of the methemoglobin concentration. And during perioperative period, we have kept methylene blue, which was given, which was intimated to Anuradha madam, and she somehow procured it, and we could keep methylene blue continuously throughout the patient's stay in the hospital, and for emergency purpose. But luckily, she was always having methemoglobin levels after the admission till the discharge, only around 2 to 3% to max of about 5% in between. But her saturations were always between 89 and 94. She was not given any other offending agents, and we ruled out drug history, and there was no drug history with her, no use of DAP, so no use of any offending agents, a long-term treatment for any other or medication. So after the surgery, during surgery, we have given we have monitored her with invasive outline monitoring, and continuously pulse oximeter was checked, and it was between 89 and 94. But SAO, as I've seen in ABGs, the methemoglobin levels were around 1% at one point of time, and there was never need for giving IV methylene blue. That was the thing. Though we have kept it ready, we didn't give methylene blue IV. And after shifting to the room also, she was reevaluated and discharged in a stable condition. So these are the references. Thank you. Last slide, please. Sorry for all the delay. Sorry for all the hiccups of PPT presentation.
ఎక్కడ నువ్వు హాస్పిటల్ లేవమ్మా?
లేదు సార్, నేను చైతన్యాన్ని పంపించి నేను ఇక్కడ ఉన్నాను సార్ ఇంట్లో. I requested her.
చెప్పమ్మా.
అంతే సార్, I requested her to do these 2 cases today so that I can present here.
Yeah, fine. Very nice, very simple and easy, and you have made a lot of pathophysiology by explain yourself, and with examples, and very good history of that boy who is taking methemoglobin, and as well as clear-cut pathophysiology, an example of our own cases and everything. Your preparation is full. The only presentation hitch was there, because if you had been in hospital, much better.
Yes,
and for presentation wise and topic wise, subject wise, nothing is pending, including the presentation preparation also. Only the technical issue. So what I would like to know is who is attending the classes now? Any student is there? Any student is there? Lambu Jambul evaru unnara?
Sir, iddaru unnaru sir.
Unnaru. Em peru? Okati Ravi Kumaru, inkoti
Kranti sir.
Kranti. Okay. Kranti.
Good morning, sir.